Trigeminal neuralgia. Trigeminal neuralgia is inflammation of the trigeminal nerve, causing intense facial pain, paroxysmal, sharp pain and followed by lacrimation, facial spasm. It is also known as tic-douloureux because the intense pain can cause patients to control their face into a grimace and cause the head to move away from the pain, causes trigeminal neuralgia. Most often, the cause of trigeminal neuralgia is idiopathic. There are some instances when the nerve can be compressed by nearby blood vessels, aneurysms, or tumors, causes trigeminal neuralgia. There are inflammatory causes of trigeminal neuralgia because of systemic diseases including multiple sclerosis, sarcoidosis, and Lyme disease. There also is an association with collagen vascular diseases including scleroderma and systemic lupus erythematosus. Symptoms of trigeminal neuralgia: acute onset of sharp, stabbing pain to one side of the face. It tends to begin at the angle of the jaw and radiate along the junction lines between the ophthalmic branch V1 and maxillary branch V2, or the maxillary branch V2 and the mandibular branch V3. Symptoms of trigeminal neuralgia: the pain is severe and described as an electric shock. It may be made worse by light touch, chewing, or cold exposure in the mouth. In the midst of an attack, affected individuals shield their face trying to protect it from being touched. This is an important diagnostic sign because with many other pain syndromes like a toothache, the person will rub or hold the face to ease the pain. Symptoms of trigeminal neuralgia: while there may be only one attack of pain, the person may experience recurrent sharp pain every few hours or every few seconds. Between the attacks, the pain resolves completely and the person has no symptoms. However, because of fear that the intense pain might return, people can be quite distraught. Symptoms of trigeminal neuralgia: trigeminal neuralgia tends not to occur when the person is asleep, and this differentiates it from migraines, which often waken the person. After the first episode of attacks, the pain may subside for months or years, but there is always the risk that trigeminal neuralgia will recur without warning. The International Headache Society has established criteria for making the diagnosis and includes the following: paroxysmal attacks of pain lasting from a fraction of a second to 2 minutes, affecting one or more divisions of the trigeminal nerve. Pain has at least one of the following characteristics: 1. Intense, sharp, superficial or stabbing, or 2. Precipitated from trigger areas or by trigger factors. Attacks stereotyped in the individual patient. No clinically evident neurologic deficit. Not attributed to another disorder. Triggers: shaving, stroking your face, eating, drinking. Brushing your teeth. Talking. Putting on makeup. Encountering a breeze. Smiling. Washing your face. GBR Clinic, incidence 4,3 per 100.000 populace/Tahun. Perimpuan greater than Laki, 1,17, 1. Seringpada Yuja du Asasada 40 thn, Ditamakan Yugapada Anak Yuja 12 thn. Nairi Tajem Minujuk Separati Keystrom Listrik, greater than 20 to 30 Dedic Sakara paroxysmal. Unilateral, 97%, Dapat bilateral. Paling Seringpada Kabang K2 and 3. Precipitasi Mangunya, Mangjijit, Contact Padada Era Trigger Zone. Anatomy Transmissi Impulse. Rosin Nairi. Receptor Nosi Septif Myophale. Sarabutafrat Urtan Pratama, first order. Nervus trigeminus. Ganglion trigeminus. Brainstem Setengi pons. Cab. Segment spinalis. Cerviculatus C1, C2. Medullary dorsal horn, MDH. Equals spinal dorsal horn, SDH. Barakert TNC. Neuron afferent urtan kedua, second order. Neuron afferent urtan kediga, third order. Cortex somatosensories. Cortex somatosensories seconder. Podesat and Abilamata test yang reliable dalam mendiagnosa trigeminal neuralgia. Jadi diagnosa trigeminal neuralgia dibuat berdasarkan anamnesa pasien secara teliti dan cermat. Zakrajewska, 1995. Treatments and drugs. Medications: anticonvulsants, antispasmodic agents. Carbamazepine, phenytoin, clonazepam, as, valproate, baclofen. Antispasmodic agents, treatment for trigeminal neuralgia. Idiopathic trigeminal neuralgia most often is treated with good success using a single anticonvulsant medication such as carbamazepine, Tegretol, gabapentin, Neurontin, Gabapentin, baclofen and phenytoin. Dilantin, Dilantin 125, may be used as second-line drugs, often in addition to carbamazepine. In many patients, as time progresses, carbamazepine becomes less effective and these drugs can be used in combination to control the pain. Should pain persist and medication fail to be effective, surgery or radiation therapy may be other treatment options. Lamotrigine, Lamictal, may be prescribed for multiple sclerosis patients who develop trigeminal neuralgia. Types of rhizotomy include non-medicamentosa surgery, microvascular decompression, gamma knife radiosurgery. Types of rhizotomy include glycerol injection, balloon compression, radiofrequency thermal lesioning, electrical stimulation of nerves. Complementary and alternative treatments for trigeminal neuralgia include acupuncture, biofeedback, vitamin therapy, nutritional therapy, electrical stimulation of nerves. New patient, carbamazepine, CBZ, allergic response or other severe side effects. Relief, partial relief. Continue. CBZ, CBZ plus, phenytoin, phenytoin or oxcarbazepine. Reduce, slowly. Relief, no relief. Relief, no relief. Continue. CBZ plus, phenytoin, CBZ plus, baclofen. Continue. Phenytoin, baclofen. Reduce, slowly. Reduce, slowly. No relief. Relief, no relief. Relief. Algoritmotherapy medicamentosa trigeminal neuralgia. 1. Relief. No relief. No relief. Relief. Continue. CBZ plus, baclofen, lamotrigine, or valproic acid, clonazepam. Continue. Baclofen. Reduce, slowly. Reduce, slowly. Surgery, tricyclic, antidepressant. No relief. Relief. Continue. Algoritmotherapy medicamentosa trigeminal neuralgia.